Hello, my name's Tom Bartholomew, and today I'm going to be doing a bit of a primer on the subject of clinical supervision. And glad you could join me. My group is part of an academic affiliation between Rutgers University and the Department of Health and State Psychiatric Hospitals. My department is called the Department of Psychiatric Rehabilitation and Counseling Professions, and my working group is the State Hospital Psychiatric Rehabilitation Initiative, or SPRE. So what do we do? We're part of this long-term academic affiliation, as I mentioned, and our mission is to improve the quality of care provided at New Jersey state psychiatric hospitals through consultation, education, program development, evaluation, using psych rehab goals, values, and principles, as well as current research. So today, in the primer on clinical supervision, I'm going to talk about the history of clinical supervision, at least from nursing and some of the oldest literature on supervision. And also, we're going to explore the difference between clinical supervision and administrative supervision, something a lot of people get wrong. And lastly, we're going to talk about the three functions of clinical supervision. And I think this is the real takeaway, hopefully, from this presentation. It was very helpful to me to learn this information. All right, starting with the history of clinical supervision, a woman named Carol Yedich did extensive work in this area. And she found that supervision began largely in nursing and involved trying to support nurses in their very difficult role, and this was primarily in England. And so it was started as an effort at support. Historically, at least in England, a large change happened when this woman, Beverly Allett, was accused of killing a number of young people with serious developmental disabilities in an institutional setting. And the outcry was, why wasn't anyone watching, and who's supposed to be supervising this person? Now, this, of course, alleged. I think she was, in fact, convicted. From this event, an Allett Commission was formed to look at the role of supervision and how it may be used to prevent just the kind of thing that occurred there. Unfortunately, this seems to have led to supervision becoming more about scrutiny versus support. And I saw in the literature the term snoopervision to capture this idea that the people started to think of supervision as somebody watching me in an effort to catch me doing something I shouldn't be doing. And unfortunately, the role of supervision took a backseat or was eliminated completely. So administrative supervision versus clinical supervision, a very important distinction between the two. So administrative, and this comes from Alfred Kadushin, who's a very popular writer in the area of social work. He said that the administrative aspect of supervision was the promotion and maintenance of good standards of work, coordination of practices with policies of administration, the assurance of an efficient and smooth running office, time, attendance, documentation, and logistics. So I think this is a terrific way to describe this. This is about people doing what they need to do. Doesn't matter if you're a great clinician, if you don't show up and you don't document, it's not going to work out. So that's what administrative supervision is, the promotion and maintenance of good standards of work. It brings us to, what does clinical mean? And this is not as easy as it sounds. I've asked many people what they thought the word clinical meant, and I didn't know it until I looked it up. But we have a sense that it's something that's working with people, right? It's, generally some ideas. Here's the definition I like. So clinical is applying objective or standardized methods to the description, evaluation, and modification of human behavior. So clinical supervision then would seem to be focusing on these objective and standard methods to describing, evaluating, and modifying human behavior. That seems pretty close to the mark to me, and presents what I think is a good distinction between administrative and clinical supervision. So what does this mean, objective and standardized methods? So many people have heard about treatment adherence standards or fidelity standards. I often talk about the critical ingredients of a practice as being the treatment adherence standards. So the things we should be doing based on whatever theoretical orientation we're coming from. So that's what that's what an objective or standardized method is. It's what is known about the subject. It's the evidence about what kind of staff interventions or behaviors produce the best results. So from this, we can drift, right? And drift occurs when staff attempt to implement these objective or standardized practices, but it leads to unintended changes in clinical behavior. So they may revert back to a preferred method of doing something, something that they could be sloppy behavior. It could be something they learned prior to being exposed to the evidence. I think of shame as like I'm going to use shame as a clinical intervention to try to get the person to change their behavior. And of course, there's some real downsides to trying to shame a client. So I'll talk now about the three functions of clinical supervision. And these came from an article by Inskip and Proctor. And later, it was called the Proctor model, or at least these functions came from the Proctor model. This is just a very small part of what that model talked about. It was also called the Alliance model. And there's a good bit written about this, particularly in England and Europe. So what are the three functions? Restorative, formative, and normative. Interestingly, in 1976, some 17 years prior to what I'm calling the Proctor model, Alfred Kadushin identified these same three functions. And you saw the definition already of the administrative function. But he also added the educational function, which is the development of each individual worker on the staff in a manner calculated to evoke her or his fully to realize her possibilities of usefulness. And supportive, maintenance of harmonious working relationships, the cultivation of a spirit de corps, like a group spirit. So it's interesting. So even though Proctor came much later than Kadushin, Kadushins don't rhyme, and so they've got to be inferior, right, if they don't rhyme. All right, but let's talk about these three functions, and we'll unpack them. Remember, they were restorative, formative, and normative. I'm going to start with restorative. So the restorative function of clinical supervision is often overlooked and underappreciated. And the idea of this function is that clinical supervision has a role in supporting emotional processing. And this can include what can be called reflective practice, where you reflect on what it is you're doing, why you're doing it, how you feel while you're doing it, and what it's doing to you, right? So sometimes working with folks that have experienced significant trauma can be quite difficult for the practitioner. And the very empathy that many practitioners rely on can be harmful to the practitioner because in essence, you're feeling the pain of the other person. And over time, that can be more and more difficult. So restorative supervision supports the emotional processing, reflection, and particularly self-care while supporting personal and professional growth. So this includes team building, and this function can be really critical to build resilience over time. Without support, staff can fall prey to burnout, which may not sound bad, but the actual syndrome of burnout involves a cynical outlook in which a staff person can feel so overdrawn emotionally that they try to protect themselves by distancing themselves from clients. And over time, this can lead to a real low sense of personal effectiveness where you're just overwhelmed and you don't have any more to give. And so one of the reasons you have high turnover in the mental health profession is this experience of burnout, where it's just too much to do long term. So the supportive function, the restorative function, is one way to give back and replenish and stay focused on taking self-care, which is absolutely critical. All right, so I used to think that the restorative function was 1/3 of the puzzle, but I've come to believe that the restorative function is in fact a larger piece than that, and that if we want folks to engage in the other functions, we really want to get the restorative function correct. So one thing you can do, there's really no limit to the ways to try to address the restorative function. One thing we can do is a self-care round, where we can, in say group supervision, we can simply go around and say, like, how are you taking care of yourself? And is that working for you? And if not, you can opt to commit to an additional self-care activity. So I was at a training recently, and a psychologist raised her hand and said, well, as psychologists, we know we need as much support as our clients do. And I immediately saw the truth in that, and realized that I think very few healthcare professionals would say that they get as much support as their clients. And of course, their clients may need a lot more support in many ways, and sometimes instrumental support, including housing and things like that. So the one thing we do is a self-care round. Some other, you can do team building, but I think being open to talking about how we are doing in the face of the kind of work we do is really critically important. All right, let's jump to the second function, the formative function. And if you think of formative, you can think of forming new skills. The formation of a new way of doing things can be taking on a new clinical practice, or brushing up on a practice we've been doing for a long time. So the formative function is all about clinical competencies. It's where they're taught, shared, practiced. They're the skills, knowledge, and values of the supervisee are enhanced. So the formative function, people often think of clinical supervision as, when they think of it as a developmental model. So new people coming into the field, and they need some process to help shape their professional trajectory. But even folks that have been doing this for a long time can take on a new practice or revisit something they're already doing. So for example, motivational interviewing or a cognitive behavioral approach, which is very popular right now. I've come to think of the formative function as a way to shape the culture of an institution as well as just learning clinical skills. But I'm going to let you chew on that by yourself. So here's some strategies that we've used, I've used in my work, including mini trainings where we can do a round where each person presents on a different clinical topic. You have to be a little careful about this. You want to make sure that the information is correct and helpful. My sense, though, is people take this very seriously, and I have not been overly concerned about misinformation. A standard is clinical case presentations. We can review theories, review the agency's missions, tenets, if they've been described, and philosophy. One of the hallmarks of the formative focus in clinical supervision is a direct observation of practice by the supervisor. And this can be critically important because there's very good evidence that the clinician is often unaware of how well they're doing or staying true to a clinical practice. And sometimes they're doing better than they think, and sometimes they're not doing as well as they think. They tend to be all over the place. There's another way of thinking about this. If direct observation of practice is too burdensome for the supervisor, a proxy observation can be used. And so in this case, a person may bring a case description in which the case formulation is in terms of a particular treatment philosophy. So for example, dialectical behavioral therapy is a principle-based practice. And if you're doing a case formulation, you would hear those principles laid out in the formulation. And if you don't hear them, then that would be a good area for feedback. And speaking of feedback, the gold standard of the formative function is audit and feedback. And audit and feedback involves a direct observation of practice, ideally could be a video or audio tape of practice. And comparison, then the supervisor compares what they see ideally with a valid measure of that practice, the way it's supposed to be done. And then they feed back the information about how close the person was to that standard. And this has been well studied. There's a Cochrane review in which 141 randomized controlled trials were reviewed. And they found that this approach had a large measurable effect on the change of clinical practice. You can see the reference down there. It's Ivers 2014. We do have a handout of that, and here it is, because you're probably watching this tape and you don't have a handout. But what's critical to know about the best practices in audit and feedback is that it's critically important that it not be a spanking, but instead that the supervisor is a trusted and supportive person, and that there's an agreement that the person being audited wants the feedback in order to get some insight into how they're doing and how they can improve. But just a couple examples. I would encourage you to either check out that article or pause on this. There's a lot on this slide. But you can see the practice is broken down, and under audit, that it's critically important that the audit be valid. In other words, that if the clinician were to change their practice in the direction of the feedback they receive, that outcomes would go up. And that's what is meant by valid in this case. Should be recent performance, and it should be about the individual's own behavior, not the team's, right? It has to be something that the person can change. And that the audit cycles are repeated with new data each time and repeated frequently. And then the idea of giving the feedback in a multimodal way. So we did it where we wrote it and then we talked about it. Hopefully the supervisor is trusted. And the feedback includes comparison data with relevant norms. And so we've been using certain practices for many years, and so we have norms built up over time. We know what kind of audit scores and audit feedback are considered normal or typical. Then in terms of what's expected regarding change, the idea is that the target behaviors that we're shooting for with the staff can be changed due to feedback. It's something the person can change. And that the person not only is capable of doing it, but takes responsibility for that improvement. In other words, it's not the supervisor's responsibility to make changes or attempt changes. It's the clinician. And then lastly, target performance goal is provided. Very common in clinical supervision for the supervisees to establish goals that they're trying to accomplish, clinical goals. So things they're trying to improve upon. And so shooting for those goals can give some sense of ownership to the clinician. And again, it's not a spanking. All right, so we've set, and sometimes if the organization is implementing cognitive behavioral interventions or dialectical behavioral therapy or motivational interviewing, whatever it is, that goal can be set by the organization. And then you've heard the term SMART goals, but it's the same here: specific, measurable, achievable, relevant, and time-bound. And then lastly, a clear action plan is provided when discrepancies are evident. So once the person receives feedback, what's the plan to move towards a higher score on the audit? And that's basically it. And that's the gold standard for audit feedback and for the formative function. All right, the last function. You're almost there. People, stick with me. The normative function is one of accountability, and it's closest to administrative supervision. And so oftentimes organizations or supervisors, they simply don't have the resources to split administrative and clinical supervision, although it is a best practice to try to split them when possible. Meaning, if I'm your clinical supervisor, I'm not your administrative supervisor. And you'll see why that is in a moment. But the normative function is the idea of keeping practice in line with professional and organizational ethics and norms, as well as the evidence that exists for effectiveness. So it's really an accountability function. It's also that smooth running office, right? If the person's not showing up, that's a problem. And so the alliance model doesn't really include this notion of administrative supervision, but it's understood that not every organization can separate them due to how burdensome that can be. All right, so one of the things in the literature that I found very helpful and important is this idea of a tension existing in clinical supervision between the need for the supervisees to feel safe, the idea of psychological safety, and the need for accountability. And so you can see particularly if I'm your administrative supervisor and I'm like, what do you need to do this and you need to do that. And how are you doing? Are you doing okay? Right, it can cause quite the tension. Not that it's insurmountable, and certainly people do it all the time, but it is something to be aware of and to talk about. All right, so gave you the overview of the three functions of supervision. They are restorative, formative, and normative. Why don't you say that with me? Restorative, formative, and normative. And if you can accomplish those three functions, you're on your way to becoming a good supervisor. So what can impact the effectiveness of clinical supervision? The first one, and I've seen this happen, I've done it myself, is that administrative issues take up all the time. And so, for example, we get to talking about a practice that we're doing in the hospital, and they say, oh, we can't get the clients to the group, like they're taking forever to show up for one reason or another. And people vent about it, and we end up using the session talking about the difficulty getting clients to the group. Critically important. If they're not in the group, you don't have a group. But the other side of it is, of course, if that's all you talk about, the group will not get better, even if it were to occur. And so what we tend to do is, for things outside the scope of the supervision, we have a parking lot. And we say, all right, I'm going to, as the supervisor, I'll take that to my supervisor or to the next level up, and we'll try to bring some leadership to bear on that problem. The second thing that can affect the effectiveness of clinical supervision is what I call a tyranny of niceness. And I got into this field because I'm a nice person. I want to be a nice person. I want to be liked. And so as I became a supervisor, I brought those same qualities of wanting to be a nice person and wanting to be liked. And when in fact, what my supervisors need is really some concrete feedback. And sometimes that feedback is difficult to give and can cause some tension. So if you're not careful, niceness can become tyrannical and not helpful. So if you're a new supervisor, give yourself a niceness check. Thirdly, it's very possible that as the supervisor, you will have people in the supervision that don't want to be there, that they're externally motivated to be there, meaning they're told they have to come. And that's usually indicated, I don't know if you can see me up here in the upper right corner. That's when people have their arms crossed and they're just staring at you. That's a good indicator that they're externally motivated. That type of group requires some different approaches than the internally motivated group, which are folks who want to do the practice. It's their profession and they're really motivated and into it. So in future editions of this training series, we'll talk about some of the different strategies between internally and externally motivated staff, how to work with them. And then lastly, this idea of an overly transactional leadership style. So you may have heard the terms transactional or transformational. And transactional is, I'm going to tell you what to do. And sometimes leaders have to do that. Supervisors have to do that. It's part of the role. But when that becomes the predominant interaction style, it can really be problematic. The alternative of that, something more transformational, which is to say, why do we do this kind of work? Let's talk about what is this about for us, and what's the importance of this kind of work, the big ideas, big philosophy. All right, so that was a really quick journey through a primer on clinical supervision. And here are the microscopic references. I encourage you to read all of these articles. I did. Didn't kill me. And so just to recap, you want to focus on the 3 functions of clinical supervision: restorative, formative, and normative. And if you do that, there's a good chance you're moving in the right direction as a supervisor. So thank you so much. I'll see you next time. Feel free to take the post-test to this, as well as fill out a training evaluation. Thanks a lot.